So good evening everyone and welcome to this no thrombosis workshop for today evening, and please allow me to share my screen. Um, can Kalpita, can you confirm if you can see my screen?
This is perfect, Dr. Pratiksha.
Okay,
Yes,
thank you,
perfect.
sir. So once again, welcome, and let me introduce our faculty for today's evening workshop. So the first one is Dr. Professor Manmohan Mehendirita, and he's the course director of today's workshop. He's the Principal Director and Senior Consultant, Department of Neurology, Dr. B.L. Kapoor Hospital Center of Neuroscience. He was ex-director professor in Department of Neurology in Govind Ballabh Pant Institute of Postgraduate Graduate Medical Education, and also in Janakpuri Super Speciality Hospital, New Delhi. He has various publications, almost 196 paper publication in many international and national journals. He has been past president Indian Stroke Association, Asia Pacific Stroke Association, Indian Society of Neurosonology, and board of director for World Stroke Organization. He has been editor in chief in International Journal of Epilepsy, and he has published 3 Cochrane reviews, has book published on puzzling cases in stroke, and subscribed 3,000 copies. He has also produced 1500 MCQ for postgraduate and postdoctoral entrance on NEET pattern. Welcome, sir, for today's meeting.
Thank you so much. I'm humbled by your introduction. Thank you.
Thank you, sir. The first moderator for today's session is Dr. Anshu Rohtagi. He's a senior consultant, Sir Gangaram Hospital, Delhi. He stands out as one of the most trusted and accomplished names in the field of neurology. He's widely regarded as one of the best neurologists at Sir Gangaram Hospital. He brings about an unmatched experience in diagnosis, management, and treatment of complex neurological disorders, particularly movement disorder. He's also a passionate educator, playing an instrumental role in training the next generation of neurologists by sharing his vast clinical experience and knowledge. His involvement in medical education and mentorship has made him a respected figure among both peers and students. Welcome, sir, for the today's meeting. We have our second moderator, which is Dr. Professor Punit Agarwal. He is the Principal Director, Neurology, Max Super Speciality Hospital, Saket. He has done his fellowship in critical care, neurology, and stroke in UCLA, Los Angeles, USA. A training fellowship in Spain and Amsterdam in DBS, Parkinson's disease and injection, botulinum toxin. Training fellowship in sonothrombolysis, TCD, and carotid Doppler and sleep study in National University Hospital, Singapore. He has many awards and accomplishment to his name. To name a few: Health Excellence Award in Neurology from Central Health Minister in December 2016. Presented European largest series of thrombolyzed cases of stroke in India. Has been awarded for best platform paper presentation in prestigious Indian Academy of Neurology and UP Neurocon. Biography been published in Repose World 2006 book in New Jersey, and Best Young Teacher Award in 2003. He has contributed to more than 55 publication and chapter in peer-reviewed reputed index journal and textbook like Nature, Cochrane, Lancet, and various others. Welcome, Dr. Puneet Agarwal, to this meeting.
Thank you.
Then we have a speaker for our today's session, Dr. Satyan Nanda. He's a senior consultant and HOD Department of Neurology, Yatharth Wellness Super Speciality Hospital and Heart Center, Noida. He's done his MBBS from Bangalore Medical College and Research Institute, MD from King George Medical University, Lucknow, and DM Neurology from Sri Chitra Trinal Institute of Medical Science and Technology, Trivandrum, Kerala. He has been awarded bursary for attending 23rd and 24th World Congress of Neurology under the aegis of World Federation of Neurology at Kyoto, Japan and Dubai, UAE. He has presented poster in both of these congresses and in many other national and international platforms. He has more than 10 publications in journals of international repute. And with this, I would like to hand over back to the sir to please proceed with the meeting.
Thank you so much, Dr. Pratiksha. Once again, very nice of you for such a good introduction of all of us. And today's workshop is KNOW workshop, that is no thrombosis. And later I will say, as you have highlighted in the center, from KNOW to NO thrombosis, so that we have strategies if there should be no thrombosis or if it happens, what to do in early phase. So I'll show some slides to lay the background. I'm very honored to have three distinguished colleagues, Professor Anshu Rodgi, Professor Puneet Agarwal, had the opportunity to work together in GB Pant Hospital for a long time. And then Dr. Satyananda, when I came into the corporate sector. So when I joined, he and me, we worked together in BLK Max. So welcome all the three dear colleagues, and they are going to do wonderful contribution to the workshop. So I laid out the foundation first that, yeah, I think this is visible, and now I'll make full slide. Yes. So how did we start the process? The first thing you will see report on 4th Asia Pacific Congress against stroke, which we organized, and Dr. Puneet will remember, there was almost strokeologists from the world in India Habitat Center, and I published this in International Journal of Stroke. Then comes post-thrombolysis Muzaffar Ali. I'll not show details. 24 September 2012. In GB Pant, there was no emergency, but I was very keen to do emergency after returning from WHO Critical Neurology Fellowship. And we did the first thrombolysis at that time, and TPA was available in the hospital free of cost. Then comes even thrombolysis PPT. The first presentation I did in thrombolysis was on 4th January 2002, 23 years and more than six months back. Then Journal Club thrombolysis, I encouraged my colleagues, and Dr. Amit Kulkarni did this on 17 December 2011, when the TPA has come to India and we have started using that. So then I am currently in BLK Max, and I will speak on thrombolysis in ischemic stroke, temporal evolution, and way forward. I'll show only glimpses, but later on sum up in the end. So I wish to thank Professor Lou Kaplan, lending me some slides when he's a dear friend and he's in US. He's the father figure in the field of stroke. Now, status of stroke worldwide, we all know. I'll not read each and every this. About 70% incident strokes are ischemic. What we found in our study was 84.7% as ischemic and 15.3 as hemorrhagic. Dr. Puneet Agarwal, one of the authors in stroke in young analysis we did in 127 out of 940. Puneet will remember when he really spoiled his clothes and hands with the dust on the files working in the MRD. You remember, Dr. Puneet?
Yes, sir. Yes, sir.
And then we have Lancet Neurology publication, which provides a systematic review on burden of stroke 2016, and fortunate to be one of the collaborators in this. Then findings are, these are the findings. Again, time will not permit, but one can read grossly, and most of the neurologists, we know that what is this, that the estimated global lifetime risk of stroke, age 25 years older, was 24.9%, which is very high. So that's what we have to prevent. When any patient comes, there are young neurologists, comes to the emergency. We were on CT scan protocol in GB Pant, later on shifted to MRI in BLK, but again shifted to CT scan. Because quick way is to rule out interstitial hemorrhage. But now we want to know DWI and flare mismatch so that we can give either RTP or TNK in time. So this is what I wanted to show in this slide. I made around 25 years back this slide. So currently available thrombolytic agents include streptokinase, high risk of bleeding, urokinase, high bleeding, pro-urokinase, high risk of bleeding. Then came alteplase, 1995, NINS trial, retiplase, tenecteplase, and any striplase. So this is slide again I made that we have to look for the core and penumbra. Even now, emphasis is we can save the core. So when we say no thrombosis, the thrombolytic agent, and then preventing by means of anti antiplatelet drugs, which are now 7 or 8 available in the market. So this one, I will leave this. These were the consortium. And NINS trial was a landmark study when you started using TPA after 1995. I'll skip those slides and then show something. This was by critics were Lou Kaplan, Mohr, and Chrysler. It was not that it was unanimously accepted that we can go with RTPA. So other IV trials and registry trials in Europe, ACUS, I had the opportunity to work with Professor Akas, principal investigation, Professor Varner Hake, who is coming for the Himalayan summit in Nepal, and we all will be joining him there. And like means there was no requirement for vascular imaging. So then developed 2000 to 2014 exclusion criteria, but most of these, as is written, were unnecessary. So I will not, then now pre-hospital management. Drip and ship is very important. It has started in our country also. Many of these pre-hospital ambulances have CT scan in the ambulance. So this is a very important thing which we need to evolve in our country. So now I think I'll stop here, and in the end, I'll go to various trials which have been done and give the final message after the case presentation by my dear colleague Satyananda and discussion by Professor Puneet Agarwal and Professor Anshu Dhotre. Dr. Satyananda, please.
Hi, sir. Good evening. So I'll start sharing my presentation. Basically, I'll be presenting two cases. So this is the first case. This is IV thrombolysis in high-risk acute stroke with detective place in 3 to 4.5 hours window. So why I deemed this case to be high risk, I'll outline this in the further slides. And this patient, although presented within 3 hours, was taken up for thrombolysis at approximately 4 hours after the onset of ictus. So brief run up regarding the patient's case history. She's a 74-year-old female. She presented to a hospital with acute onset left-sided hemiparesis with left-sided facial palsy and dysarthria since 11:45 p.m. on 24th of October 2023. She had a significant past history of hypertension, obstructive sleep apnea, and hypersensitivity pneumonia. She was already on medications for all these ailments, and she was very well compliant to these medicines. Also, she had a history of left MCA territory infarct, which was 2 years ago. And thereafter, she had been advised to take Ecosprin 75 and Etorva 20 mg, and she was very well compliant on those medicines. She reported an allergy to sulfur drugs. When she presented, her blood pressure was 200 by 110 millimeters of mercury, and other vitals were relatively stable. And she had a disabling stroke, as evidenced by an NHS score of 11. So briefly, I'll just run through the patient's clinical examination. She had paralysis of the left side of the body, and there was a facial weakness also, and the speech was also slurred. Excuse the fact that I could not blur the total picture. Excuse me for that.
Hello. Good evening. Actually, I'm giving one lecture. I'll give you a call slightly later in the night, in the evening. I'll call you. Okay. Okay.
So as is evidence from this video, she had a disabling stroke, and she was barely able to lift the left leg and left arm above the bed, and barely able to sustain it. So she had a disabling stroke, and thereafter, we proceeded for imaging, brain imaging. So, because she had a history of previous stroke and her blood pressure was also an issue, I was cautious regarding the fact that on CT we may miss other additional information like microhemorrhages, or whether what was the size of the previous stroke, what was the location of the stroke, and per se as to what the size of the current infarct would be given the disabling symptoms. So I proceeded with MRI rather than opting for CT. So this is the diffusion weighted images of the patient. So as is evidence, she had a right MCA territory infarct, and there was an old chronic, sorry for that. Although the images were a bit blurred and because of the motion artifact, but it was still enough for me to take a decision that the MR aspects was not very high. Probably it was 2. And thus we could consider her for thrombolysis also, as she had presented within the window period. Next of interest was to see whether she had any major microhemorrhagic burden, or whether she had any silent hemorrhage which was not detected or not reported by the patient. So that again, the image quality was quite degraded, but it was sufficient for us to assume that there was no major hemorrhage uh, which had ever affected the patient. There's a GRE image. It is quite distorted, but because the patient was not in a full senses at the time of the MRI, the images were not retaken also. Thereafter, the next important thing was whether the flare was showing positivity or no, whether the flare signals were positive or no. Flare signal was negative, and there was a diffusion flare mismatch. All the more reason for us to consider IV thrombolysis in this case. As you can see, this area is totally without having any flare hyperintensity. So all said and done, the patient presented to the ER within the window period, and she had a disabling stroke, and her MR imaging was also in favor of thrombolysis. There was no contraindication for us not to give thrombolysis, except for the part that she was having elevated blood pressure at the time of presentation. So it was 200 by 100, and we needed to bring it down. And this is the status of the vessels also, which was done at the same time. This ruled out that there was no major vessel occlusion, and thus the patient wanted IV thrombolysis only. There was no need for any other therapy like mechanical thrombectomy. The MCA were very well formed, as was the ICA. So, in view of elevated blood pressure, the logical thing was to give her IV labetalol 10 mg, which was repeated. And thereafter, the blood pressure did come down to 174 by 90 millimeters of mercury. And the attendants were thereafter counseled for IV thrombolysis, its risks and benefits. I did explain the slightly increased risk of hemorrhagic conversion. Usually, we say it to be 6 to 8%. I told in this case it may be mildly, it may be slightly higher because in view of accelerated hypertension at the time of presentation, and the fact that the patient was already on single antiplatelet agent. Usually, the double trouble is accelerated hypertension with dual antiplatelet, but because she was on single antiplatelet, also that also lended risk for IV thrombolysis. Thereafter, there was a delay due to deliberation from the attendants, and the consent was given. And when we rechecked the BP, again, it was 190 by 100 millimeters of mercury. Then again, we gave 10 mg of labetalol, and after the BP was noted to be approximately 180 by 90, she was given thrombolysis with tenecteplase. So in totality, we gave 30 mg of labetalol, which is fair enough, and which was well within the stipulated standard of maximum 40 to 60 is what AHA guidelines say that we can go up to 60 mg of labetalol prior to thrombolysis with any of the agents, thrombolysis with tenecteplase or alteplase. So now the decision which was to be taken was, I think we can deliberate on that. Probably the moderators will help us in deliberation with that as to what the dosage should be given for tenecteplase. Should we stick to zero point 0.2 or should we give 0.25 mg per kg? Because there has been a lot of Western data which has pointed towards better results with tenecteplase 0.25 mg per kg, because it's such a molecule that once we prepare the patient and all, we all of us are also hoping that there will be a result. There will be the improvement which will happen in the patient's motor deficit, and the patient will go on walking. So the deliberation was of that only, that whether we have to consider 0.2 mg per kg or 0.25 mg per kg, because the patient had accelerated blood pressure and she was on aspirin. I proceeded with the lower dose, that is 0.2 mg per kg body weight, and she was thrombolized 4 hours after the onset of symptoms. The door to needle time was definitely prolonged because of the delay in the imaging also, and the first subsequent delay in managing the blood pressure and taking the consent. So the door to needle time was approximately 1 hour and 45 minutes. Uh, Tenecteplase we gave was 0.2 mg per kg. So post procedure, she had an improvement in her NHS score to 5. That is 24 hours post IV thrombolysis, her NHS score was 5. And on follow up, she's been following up thereafter also. She has recovered all the deficit, and she's currently not having any deficit from the uh, stroke which she suffered in 2023. So this is the post thrombolysis CT scan, and apart from a few specks of hypodensity, there's nothing remarkable. And last follow up, she had recovered all the deficit. She was able to speak well. The arm weakness had disappeared. She was able to walk also by herself. Although at the first follow-up, she did require some support to walk. That is also because of her desaturation and her other comorbidities. So, so this is the first case which I wanted to present, and this is just a literature review. If we can, do we have any objective evidence as to which dosage we can use for tenecteplase and which is better with service alteplase in terms of hemorrhagic conversion? So as we can see from the pooled estimate, the relative risk is in favor of tenecteplase when we use a lower dose, that is up to zero point 0.2 mg per kg. That is the time when that is the dose at which hemorrhagic risk is more favorable with tenecteplase as compared to alteplase. When we go to the domain of zero point 0.2 to 0.39 mg per kg, although it is still skewed towards tenecteplase, but it is not so uh, not so uh, not so significant, that is. And if we go higher up on the dosage, if we use more than 0.4 mg per kg of tenecteplase, we know that is a very big risk factor for major hemorrhages, and that has been in multiple studies. It has been found out that we should not be going for 0.4 mg per kg. That max we can restrict ourselves is 0.25 mg per kg. So this is the literature review in which they found that the rates of complications were comparable between those treated with tenecteplase versus alteplase, but the rate of spontaneous ICH may be increased in those treated with higher doses of tenecteplase. So this is another article in which there was a study which was done on safety of IV thrombolysis for acute ischemic stroke in patients who were already receiving and well compliant to antiplatelet therapy at stroke onset. So I'll just go through the conclusion that the absolute excess of spontaneous ICH uh, of 1.4% in the pooled antiplatelet group is small compared with the benefit of thrombolysis seen in randomized trials. Although caution is warranted in patients receiving the combination of aspirin and clopidogrel, antiplatelet treatment should not be considered a contraindication to thrombolysis. So many times, even when I was starting my after residency, I had started my practice. There was always a doubt in my mind also as to if the patient is having dual antiplatelets, should we go ahead with thrombolysis or no? Or sometimes these questions are not. We don't face those questions during our residency. But as we have given more and more thrombolysis, as we've learned more about these molecules, and now we have a better, safer molecule, I think we should be going ahead with uh, thrombolysis in patients who were well compliant on dual antiplatelet. After counseling the patients or their patients or their tenants, there'll be an increased risk of hemorrhaging. But even if the hemorrhage happens, it will be the risk of benefit will outweigh that detrimental effect. So this is regarding that. So key points from this first case presentation is that patients with labile accelerated hypertension and currently on single dual antiplatelet agents are at slightly increased risk for hemorrhage. And in these patients, a lower dose of safer thrombolytic, that is tenecteplase 0.2 mg per kg, can be considered for IV thrombolysis.
Thank you so much, Dr. Satyananda, for very interesting case. What we'll do is we'll bring in moderators will give their comments, and then we can take question and answer after the first case. The second case may be different. But I have two issues which I want to ask. Puneet and Anshu, both you can switch on your video and audio. One is, what was the weight of the patient?
So the patient's weight was around 90s. It was 80s to 90, something in that range. It was not
And
beyond
what
100
what was the dose used?
So 0.2 mg per kg.
No, total dose you said higher,
Uh,
30 or 40 milligram you said. Something.
no. Sir.
How much was that?
So it was 18, something
It must
18
have
or
been 14 or 16
yeah,
milligrams.
something in the 16 to
Okay,
18
okay.
range.
That's right. That's right. So, Dr. Puneet and Dr. Anshu, I'd like to invite your comments. Are you around, Dr. Puneet and Dr. Anshu?
So Dr. Anshu is not here. I guess he has some emergency, but Dr. Puneet is
Dr.
here.
Dr. Puneet, can you unmute? I think he's also not around. So, yeah, Dr. Puneet, unmute yourself.
So you are here.
So, Dr.
Yeah.
Satyam, I just want to ask, I have just missed your first slide. Was it a wake-up stroke or
No,
not?
sir. The time of
No,
onset was very well defined. She had not retired to the
11:45
bed.
p.m.
11:45.
11:45 p.m.
Wake-up stroke.
Yeah.
So, yeah, I think you have presented very nicely, and the patients of TNK with the given even in the presence of antiplatelets, lot of studies have been published that you can give it safely. And if you see the comparative data also between altiplase and TNK, a lot of data has come. In fact, in 2025, I was reading there is a meta-analysis also come, which has shown that in fact, TNK is having a safety wise equivalent to alteplase, even if you're using the antiplatelet drugs, similar results in terms of safety and in terms of early neurological outcome. Within, if you're seeing the early neurological outcome uh, within 1 hour, and your patient who are thrombolized in early, in those the TNK has performed better than the alteplase in that meta-analysis study. And later on, if it is thrombolized, it's showing the same result as compared to the alteplase. So it's a very well safe drug, and in my opinion, I used to do give the 0.25 is a standard dose, which is right now approved by AHA and ASA in Indian Stroke Association also, and per
Even
kg body
DCGI,
weight
Puneet,
as a
even DCGI is approved.
yeah, DCI is approved
0.25.
0.25 milligrams. So
Yeah.
one point which I have to convey is even in the presence of antiplate, I'll go with the 0.25 milligram per kg body weight to give the maximum benefit to the patient. I usually don't reduce the dose because there is no evidence of reduction even with the alteplase, and as well as same applied to the tenecteplase also. So so that is one point. And second is that I don't know why they were giving ecosprin 75 mg as a preventive for the acute stroke while it should be 150 or 100 mg minimum. So that remains to the doctor who was treating this patient earlier. So as was any you have told there was a last past history of stroke also there. So when
Yes,
was how many months back?
2 years back, sir. 2 years
What?
back.
So yeah, so that justifies to give the IV thrombolysis even recently also because it's more than 3 months back. Otherwise, your case, I think, responded very well. The only thing which we know till now with regarding TNK is that studies the I think the trial which was done, twist trial which was done for TNK in a wake up stroke. So that is the only thing which is remaining in comparison to alteplase, that study has not shown the favorable result. The lot of lacuna were there. I think in that study they used a CT scan as a marker to rule out hemorrhage instead of doing the MRI which was done in the wake up trial for the LT They have done the MRI and comparing with the FLAIR images, while in twist trial they have seen only done the CT scan, and they found there is no favorable response in wake-up stroke with TNK. I think studies are still going on the with the MRI criteria now with the TNK. So that is the only thing which is this is the only indication which is remaining in comparison to altiplase. Otherwise, TNK has had all the indication now to give in all cases which are in which we are giving altiplase. So that's it. That's my comment from my side. I think,
So
sir.
can
Thank you so
I
much.
am from Genoa, so I just wanted to add just make one comment about the dose. So so we know we did our studies at 0.2 mg per kg. It has been used and it is safe. But I was looking recently at some of these comparative studies. TASTE study published in Lancet Neurology, ACT study in Lancet from Professor Bijoy Menon, then ATEST2 study from Ireland. So if you carefully look actually in those studies, when you compare 0.25 versus zero point 0.9 alteplase, although because symptomatic hemorrhages are 1 or 2%, but if you look carefully, numerically, in all these studies with 0.25, the percentage of patients is actually higher. It is not statistically significant and it will not come because the numbers are small and studies are not powered for safety. But if you look carefully, and these were from one is from China, this big trial comparative from Chinese study, ATEST2 from Ireland, TASTE, ACT. So with increased dose, and we actually work with Professor Parson, who first used this 0.25 dose, and I'd asked him, and I don't know if you were there at the INSC meeting in Lucknow yet, that how that 0.25 came. Actually, there was no data on 0.25. It was the BI, they did simulations, and this is how it came. But this is just for the panel. I looked carefully at some of this data, and it was very interesting. So, but anyway, that is known, and a lot of investigators have been, as sir has used 0.2. And even yesterday, we were in Hyderabad, and Dr. Jaiswal, he's a neurologist there at one of the hospitals involved for last 15 years. He said, if just like your case, if there is any risk factor, then he uses 0.2. Some other cases 0.25. But anyway, this is the dose. And even with alteplase, I can tell you, Japan, they use 0.6. In
0.6.
Vietnam, I know I've been there, they use 0.6, 0.7. So in thrombolytics, always in that range, wherever the investigators, the clinicians are comfortable. But this is, just wanted to put it out there.
Thank you, Amit, for the important points. What you were talking was about Mark Parson from Melbourne, right?
Yes, yes.
Yeah. And the study which was done in Japan was called J-fast, that was
Yes.
0.6 milligram because
Yes.
they proposed and considered that Asian people are smaller in overall physique and habitus compared to the Western people. That's why they tried and they said it's effective.
So
Now,
Parsons was, I'm talking about Professor Parsons in terms of 0.25 dose, because he was the first one.
I'm aware. He's a dear friend, Mark Parson.
Yes.
Steve Davis. He was with Steve Davis.
Yes, Steve Davis.
Who was the president of World Stroke Organization.
World Stroke Organization. Yes.
Steve had been a visitor to India and good friend. So now I would like to ask two things to Dr. Puneet Agarwal contributed very significantly in this. Second, one aspect was that when I was seeing the angiogram, if you see M2 beyond, the network was sparse compared to on the left side. And second up was that in your first or 2-3 slides, there was search, word, whale, and dolphin day. What was that? There on the bottom it was written.
So regarding the angio, I agree with you. On the right side, there was a paucity of the terminal vessels of the MCA. Regarding the second point, I didn't understand. So
it was written at the bottom of the slide: search, word, whale, and dolphin day, something like that. It was written in 2-3 slides at the bottom.
I'm not sure. So
Okay.
I might have written something.
I'm paying good attention to your talk.
Yes, sir is
Keen
always
observer.
very much
Keen observer.
observant. Very, I'm telling you, I've been with him. So
Okay.
he is very good observer.
I think this is time to move to second case, and then we'll have discussion. In the end, what all studies, what you have mentioned, Puneet has mentioned, and also Amitji has mentioned. I will show in the end which one and why, and those things as concluding remarks for the young neurologist and for my updation also. Yeah, Dr. Satyam, second case, please.
So this is the second case, as Puneet sir had remarked, that we are still in wait of data for detected place in either a wake-up stroke or in the extended window period only. So this case will serve to highlight to us that thrombolysis in extended window period with an IV detected place is being done, and how much of an improvement are we getting, or how is it producing any adverse effect to the patients. So I'll move to the next case. This is a 50-year-old gentleman. He's a known case of hypertension. He was basically brought to the OPD with the chief complaints of acute onset inability to speak, which was noticed since 8 a.m. He basically worked as a security guard, and he had been in a night shift. Nobody had really noticed him. There was no caregiver. He had just taken a bus and come back, and he was not able to speak, and the stroke onset was unwitnessed, and the attendants were also only came to know of it when he came to the home. And due to the deficit, the patient was not able to communicate the exact time of onset. And an hour later, he developed weakness of the right upper and lower limb, and he was brought to the OPD at around 1 p.m. So we presume that it is a wake-up stroke, because it was actually not a wake-up stroke; it was a stroke of unwitnessed onset. We never knew the exact timing of the stroke when it happened. And by the time he had been brought to the OPD, precious 5 hours had already been lost. And because the time when he noticed it, more than 5 hours, I would say, because he noticed it at 8 a.m. and he was brought at around 1 p.m. So 5 hours had already lapsed. And his examination was fairly, vitals were okay. CNS did show global aphasia. And power of right upper and lower limb was 0/5. And NHS was a disabling 14 out of 38. So we went about, because again it was a stroke of unwitnessed onset. We needed more imaging data rather than just a CT, because CT would have only shown the evolved infarct if it would have shown. So we wanted to go for MRI, firstly to look for diffusion flare mismatch, and secondly, if to look at the extent of infarction if it had happened. So this is the sorry, I'll just rerun the video. So there was a I'll just let the video run through. So there was an area, multiple areas of diffusion hyperintensity in the left MCA watershed area, and this pointed to an acute stroke and was symptomatic for the patient, as he had right-sided weakness and he was not able to communicate. Also, he had aphasia. So thereafter, we looked at the flare images. So as we can see from this screenshot image, there was an area of diffusion hyperintensity, which had also come up positive on the flare. So there was no real diffusion flare mismatch to be, except for a tiny area on the post-central gyrus on the diffusion, which was positive. The flare was negative on the same okay in the flare images. So thereafter, the CT angiogram was done. The CT angio did not show any any major vessel occlusion. There was no major vessel occlusion or high-grade stenosis, at least in the proximal MCA branches. So we were not able to assess whether the patient has any tissue which can be salvaged by these techniques. So we need to go for perfusion studies. So either we can go for MR perfusion studies or we can go for CT perfusion studies. So in our case, we opted for CT perfusion imaging to see whether there was any penumbra which could be salvaged. So as we know now, the concept of stroke is shifting from only time-based thrombolysis to tissue-based thrombolysis. So that is what we were also seeking, that whether there is any tissue, any significant tissue which can be salvaged, because already 4.5 hours have lapsed by the time of reporting by the patient himself and by radiological imaging also that the flare has come positive in a major area of the infarction. So we went ahead with CT perfusion and we got it analyzed through rapid software. So in this, the CBF less than 30% was 9 ml. This is what this basically comes as a report, and this is what was given to us, that the CBF less than 30%, that is the area of infarct, that is the core. Core is already 9 ml. So if we are to look at Tmax more than 6 seconds, that is an area in which there is a risk of uh, infarction, that is the infarct area and the penumbra. The total volume of that was 25 ml. So I'll just use the pointer also. So this is the area which has already infarcted, the violet area and the purple area, sorry, that is already 9 ml. And the area which is at risk of infarction and the area which is infarcted, including that, that is around 25 ml. So if we deduct the volume of the infarct core, so the penumbra which we got was 16 ml, and the mismatch ratio was 2.8. So this again signified that there was area which could be salvaged. Good 16 ml of the brain volume was amenable to salvageability, and this was in the important areas of the brain, in the high cortical areas and in the posterior visual association area. So we patient was thrombolyzed with tenecteplase. This time the dosage, because I didn't see any major risk factors for intracranial hemorrhage, and the BP was also very well within the control. So I thrombolized the patient with tenecteplase 0.25 mg per kg, and 13.75 mg was given. It was around 6 hours 10 minutes after the symptoms had been noticed. So the patient outcome was again that he recovered a major part of his deficit. The only issue was that his aphasia was persistent, and I'll just run through the patient's outcome video. And so the residual deficit for this patient was that he had aphasia and subtle right side facial palsy and a gait instability, which was more pronounced on the right side. So at the time of discharge, he had regained the full power, but the motor aphasia was still persistent, and he had right side facial palsy. So this patient also went a follow-up scan, and the areas of infarction were again limited to the core. The penumbra had been salvaged, and as we can see, there were only a few foci. I'll just go through it again for that. Yes. This strip which we saw on the rapid software, which was having a Tmax more than 6 seconds. This was salvaged. There were a few foci which had gone, but by and large, it had been salvaged. And this was the gratification which we got from giving thrombolysis to a patient who had already presented out of the window period. But with advanced tissue imaging, we were able to see that the patient would recover. And if we are to talk about if we have any evidence for us to go ahead with this sort of an excursion, that can we go ahead with thrombolysis in 4.5 to 9 hours? So ESO guidelines are quite clear on that, that although the quality of evidence is low, the strength of recommendation is strong as per the ESO group physicians. And this was the study which they analyzed by which was done by Campbell et al. They assessed that the co-perfusion mismatch was assessed with an automated processing software, which is again that same rapid software, and defined as follows. So these type of patients can be considered for IV thrombolysis in 4.5 to 9 hours. If the infarct core volume is less than 70 ml, that is, they don't have a major chunk of the MCA territory which has been lost, and they are having critically hypoperfused volume to infarct core volume of more than 1.2, and the mismatch volume is more than 10 ml. And how do they define it? The core is defined as RB, cerebral blood flow of less than 30% on CT perfusion. And Tmax defines the core as well as the penumbra, that is more than 6 seconds. So this is the ESO guideline which recommends that we should go ahead with thrombolysis in such individuals. And just go again through that. For patients with ischemic stroke of 4.5 to 9 hours duration and no CT or MRI core perfusion mismatch, if there is no mismatch, then we should not be going for IV thrombolysis with altiplase or tenecteplase. For patients who present directly to a thrombectomy center with ischemic stroke of 4.5 to 9 hours duration, with CT or MRI core perfusion mismatch and who are eligible for mechanical thrombectomy, the group members could not reach a consensus regarding whether IV thrombolysis should be used before mechanical thrombectomy. As we usually give the bridge thrombolysis, they could not really opine whether it should be given or not. And for patients presenting to a non-thrombectomy center with ischemic stroke of 4.5 to 9 hour duration with a mismatch who are eligible for mechanical thrombectomy, 6 out of 9 group members suggest IV thrombolysis before mechanical thrombectomy. So this is an article which has been quoted multiple times, and this was published in the esteemed journal NEJM, and this paved the way for thrombolysis guided by perfusion imaging up to 9 hours after onset of stroke. So I'll just go through the results. Basically, 25 of the planned 300 patients had been enrolled. The trial was terminated because of loss of equipoise after the publication of positive results from a previous trial. A total of 113 patients were randomly assigned to the Alteplase. Basically, they used Alteplase and at full dose, and 112 to the placebo group. The primary outcome occurred in 40 patients, that is 35.4% in Alteplase group. The primary outcome was again a score of 0 or 1 on MRS, and it was achieved in approximately 1/3 of the individuals who underwent Alteplase injection. And in the placebo group, it was 29.5%. The adjusted risk ratio was 1.44. Symptomatic ICH occurred in 7 patients in the Alteplase group and in 1 patient in the placebo group. So, a secondary ordinal analysis of the distribution of scores did not show significant between group difference in functional improvement at 90 days. So, the conclusion of this trial was among the patients in this trial who had ischemic stroke and salvageable brain tissue, the use of Alteplase between 4.5 and 9 hours after stroke onset, or at the time the patient awoke with stroke symptoms, resulted in a higher percentage of patients with no or minor neurological deficits than the use of placebo. There were more cases of symptomatic ICH, which is expected, but I think with tenecteplase, ICH should be lesser in the Alteplase group than in the placebo group. So among the study design, this is what I want to emphasize on. As taken up in this study, if the perfusion lesion to ischemic core mismatch is more than 1.2, that is a good candidate for IV for thrombolysis in a mismatch case. And if there is an absolute difference in the volume greater than 10 ml and an ischemic core volume of less than 70 ml, these are the patients who are going to improve in a much better way with the molecule rather than giving just blindly for every patient. So this is in our case also the core was around 9 ml and the volume which was to be salvaged was around 16 ml, more than 10 ml, and the ratio was also around 2. So these are the type of patients which improve more with IV thrombolysis in the extended window period, that is 4.5 to 9 hours. So thank you. That concludes my case presentation.
Thank you, Dr. Satyananda. Another interesting case. Indeed, that extended window period for thrombolysis. Earlier came extended window period for MT, which has gone up to now 9 hours, and when people are thinking it may go up to 24 hours. And in the end, I will tell why. Actually, I have not written on this, but I always discuss, and I think once or twice I discussed with you also on the round, that if you see the Boyd pathology, it says molecular death sets in 12 hours. 12 hours, whether Robbins or Boyd. So molecular death means complete death, right? So I'm confident, and I often say in the rounds that it's likely that this window period may be extended up to 12 hours based on the evidence we require, not the pathological data. So I have one or two questions I'll ask later, but Dr. Puneet Agarwal, your comments, please. Any countries around
Dr.
his
Satyan
comments?
is really a very interesting case which you have presented, and I think it's really a good one. I think it's a future which is, I think, will start using beyond 4.5 hours. And you're right, you have presented nicely. And uh, although ESO has more confirmatory said about the stroke which are of unknown onset of or wake up stroke, and they have done a study on with the LT plays.
Yes.
So the only catch here is because I've also tried beyond 4.5, the only catch is medical legal issue. So till now, the DCGI or our Indian Stroke Association, as well as the American Stroke Association, ASA, has not recommended beyond 4.5 hours for TNK. And so that's the only catch. We can do that logically. That's correct, because LT has, we have done, you have used it in the studies, and up to 9 hours it has shown results. So in fact, if you use the recent trials by timeless trial and the trace 3 trial which are going on TNK only, which are using from 4.5 hours up to 24 hours. And in fact, I think this timeless trial has already completed, and they've shown that there is a favorable response with TNK if you are using it even beyond 4.5 hours up to 24 hours. And with using the parameters, CT perfusion parameter, they're slightly different from the European parameters. Like they've used a core size less than 70 ml, the mismatch ratio which you have said is more than 2, and then the the Tmax they have not used, they've used at MTT time, which is, should be increased, and CBB should be normal in the penumbra area. So that's why they've used slightly different criteria, but that's almost same. And then they found favorable response with TNK, and I think the trace 3 trial is showing uh, is showing that more favorable response with the TNK, but still it is not approved by the FDA and as well as our society. This thing, I think, then but how to deal with the medical legally, that's I'm not sure. If something happens, suppose some hemorrhage happens, and that's fine, we are giving benefit to the patient, but hemorrhage happens, which is seen in these study ranging from 1.8 to in fact 2.3 to 5%, then that will be, I think, tricky thing to handle. That how will you defend these cases in the absence of, we can't label on the basis of study, we can say that, but it's not approved till now. I think Dr. Sir has will tell about this, his opinion, whether we can use it in practice or not, till there is a recommendation.
Yeah, thank you, Puneet. And the study which quoted by Dr. Satyananda is by Professor Henry Ma, again from Australia, and he organized the last APSC in Adelaide, and I was there. So he is into research like Mark Parson. He's also doing Craig Anderson. He's also into these, but Mark Parson, they are more into the thrombolysis studies. So one is that. Now, Satyan, I will also take up the question from audience if there are any. Satan, I have one or two questions. What was the
Yes.
type of aphasia the patient has?
So initially it was receptive aphasia. He was not able to follow the instructions, but when he was discharged, it was a motor aphasia. He was able to communicate, but all the words which were coming out were jargons, jumbled speech. As it showed in the video, he was able to say his name. He was able to follow the instructions, but it was all he told his name as Fishy Singh rather than Hari Singh. So it was a motor aphasia at the time of discharge.
Because what I saw on the infarcted area was in the posterior parietal area and not in the Broca's area. That's why I was asking what is exactly the type of aphasia. That will also decide about the outcome. If it is perceptive or receptive deficit, then recovery may not be that good. So that was one point. The second I've already said about 12 hours, what was we read in third year in Boyd pathology. It's becoming like in the studies it is coming up. Maybe one or two more studies, Dr. Puneet, come, then there may be meta-analysis and then some recommendation coming from AHA or from ESO in the coming years. Yeah. So
Yes,
that
one
is
question, sir.
another
Okay.
one, one. And the other thing was diagnosed with MRI also. He also has hypoanemia. So has two. So did he have 55?
So your voice is breaking, sir. I don't get it properly. Hello.
Yeah, did he have any risk factors? He has
Yes, sir.
microangiopathy.
Regarding the risk factor, there were no known risk factors except for smoking. He had a strong history of smoking. Yeah, he had a strong history of smoking.
Yeah, the another thing which I was asking, what was the CT angio of the neck? You showed the brain. You showed the brain. Again, there are specifically in the posterior part of collateral circulation, not of the blood flow in the major vessel, but collateral circulation. But what about the CT angio neck?
So the patient never underwent a CT angio neck. Basically, did the CT angio brain and CT perfusion. So he had come from a lower socioeconomic strata. He didn't go for any other investigation except for just the thrombolysis and the investigations which I told him at the outset. So day 3 only, I think day 2.5 or day 3, he just went and was never seen again. I tried to contact his family. They only told me that he's good, acha hai, and he's taking the blood thinners. But apart from that, I don't have any. That's why I could not tell also whether what was the etiology of the stroke. I was not. They didn't give me a chance only for that.
Yeah, that's what I wanted, because if there was LVO, he could have been a candidate for MT because in extended window period. So that's why I especially asked about the neck CT.
Brain was normal, sir. Brain was
that was decreased collateral on the left side.
Left side, yes,
But,
yes.
Yeah, Dr. Puneet, any comment?
The only thing is that the type of stroke which I've seen because it was the two areas of the infarcted area seen, looking like a patchy stroke,
Yes.
multiple sites. So it's more looking like embolic to me. I'm telling you. On the MRI wise, usually it is more favoring these kind of multiple. It's not in the watershed area, but because involving the posterior parietal and this area. So to me, it's more looking like an embolic stroke. Maybe emboli may come from the left ICA or maybe AF also. So I think he did not get the testing done as you are telling me. So maybe having bolus coming from the IC or from the heart, due to I think maybe requiring workup later on whenever possibilities are there.
Very
So
good
that has
point.
to
I always say when I see the MRI and there is a string of sort of string of pulse, I say look at cardioembolic or thromboembolic, which the embolus after blocking has broken or fragmented. The second is like to quote our study of 85 subjects with posterior circulation, which was done from GB Pan, published in Neuro Hospitalis, that if you find, this was not posterior circulation stroke, but if you find posterior circulation stroke, 2/3 were cardioembolic. So please do rule out cardioembolic, especially AF, progressimal, persistent, or permanent. That must be ruled out. Or other cardioembolic cause like hypokinesia of the wall. Yeah, Amidji, you wanted to say something?
Just one, I was curious that how many of these type of patients you have treated over the year? Because I think in Indian context, it's very important. We get data, Chinese data. Sometimes, if you see some of the, they recruit thousands in 2 months. Globally, sometimes there's little bit skepticism about Chinese studies. But I was talking with Professor Henry Ma. I know him. He's at Monash University, and we're talking about connected place. He has been working a lot. Professor Parson, Bruce Campbell. They have a group there. So in Indian context, we don't get, unfortunately, there's a lot of clinical data, but it's not published. So I don't know how many patients you have, sir, treated in last few years or so. That can
Every
be.
every month, especially in the thrombolysis happens more frequently in corporate sector than in the public sector. Number one, Puneet has done a lot. Satyan has done a lot. I have also done. Means our department.
Mhm.
Every month, I think 3 or 4 thrombolysis does happen.
Sir,
I don't
from
know the
4.5 to 9, I was
no,
actually
no,
specific.
not 4.5 to 9. That is
This is what I wanted to.
only after perfusion and again guidelines as highlighted by Puneet. Very important.
Mhm.
Then you have to pen down, taking a shared decision with the family that I have explained to them that there are no guidelines. I took their consent, their name, phone number, and if they say yes, signature, then we may go ahead. So that we should,
Yeah,
all clinicians should make a practice. Yeah, Puneet.
because shared, I think consent is very, very important when you're
Yeah.
doing beyond the guidelines, है ना?
Yes.
And
Mhm.
this is very, very important for the medical legal purpose. And definitely it can be, if you report these cases, that's better, है ना? To just for the, again, for the medical legal issues. We have done a lot of here in Max Saket, we have done the mechanical thrombectomy beyond 4 6 hours. I think we have done around till now 12 to 15 cases in last few years, till since the Dawn trial and Diffuse trial has come. But so with the good results, not very satisfied, but not 100%, but good results in majority of the patients that we have done. But for the IV thrombolysis, definitely I've not tried till now because it's beyond guidelines. So due to the medical legal issue, I've not tried. So, but it's a good thing. Dr. Satyan has done that.
Mhm.
It's really good work. He has done a good work.
Because we wanted to say if we approach the DCGI, so we have some Indian data, and then it becomes easier for the authority and the association to increase the window period.
Hey,
And we may
what
be
we
doing
can do,
something in future
I think
about it.
what we can do is we can make a trial. We can do the study, and
Mhm.
then only we can do that safely. So
Mhm.
if we conduct a multi-centric trial beyond 4.5 hours, in fact,
Mhm.
I'm telling you, I've been approached by Boringa for this trial only.
Mhm.
Beyond I have opted for that. So that study going to be started at Boringa, that
Mhm.
beyond 4.5 hours for TNK.
Mhm.
So so I think they have not started yet, but I've been part of that if it is started in India. So they've
Mhm.
already started a multi-centric trial all over across the world. Beyond
Mhm.
4.5 hours up to 6 hours, they are
Mhm.
taking CT perfusion criterias and
Imaging based.
this thing
Puneet,
for this
imaging based.
imaging
Imaging
based.
based, and you are
Imaging
saying
based.
you are
Yeah, yeah,
talking of tenacity trial,
yeah,
right?
yeah, yeah.
Don't
So
worry, I'm also part of that.
yeah, that's good.
Okay.
So I think
they
this will come as sir is rightly
they
saying.
have
I think
invited us, but still not taken shape. Still
yeah,
not taken shape.
because sir is rightly saying it, that I think once the studies come and the metal is published, then definitely there will be approval from
DC.
they will come with the guidelines also. Even I think up to 12 hours, just like MI. So MI
Mhm.
similar to thing applies to the brain also. I think up to 12 hours. Hopefully, we should get a guidelines that we can treat those cases. I think.
Amit, in our country, we are very fond of saying, I have a lot of cases. I will say, Puneet will say, Satyan will say, but we don't collaborate and
Yes.
we don't
Yeah.
keep data. So this
Don't
is a
keep.
proposal for Emcure or Genova to take the lead, as he said. These trials have to be industry sponsored, but unbiased. This
Mhm.
we need to do. Similarly, for connective place point two, when Mathil Pradeep was doing and others, I am aware of that study. So recently, also you people have given me one brochure where another senior neurologist has done a study. So if we club all over India, then second is in public sector, it's easier to recruit patients. In private sector or corporate, it's not easy. because means I will not go into details.
No, sir, we know, sir. We do the trial, so we know. We know the
yeah.
reason. So, but that is true. That is true. We agree there.
Okay. So, Amit, are we taking questions from the floor, or should I just
Yes,
only
I,
concluding?
Dr. Pratiksha, any questions from the, or maybe Kalpita has any questions?
So currently, no, just checking.
Okay.
Okay, I will then give last few slides and give the
Yes, sir.
concluding remarks, if Dr. Satyan and Dr. Puneet permit me.
Yes, sir. Yes, sir.
Yeah. Okay, I'll share. So this was the one which Dr. Satyan has also given a reference about Bijoy Menon study from Calgary. He is a dear friend from Kerala, and he has done in 1600 subjects, and this study really said that this is non-inferior. We always now talk of non-inferior first rather than superior about tenecteplase versus alteplase. Then comes these were the interpretation. We don't say conclusion these days. Only after discussion we write conclusion, but in abstract summary, that's the requirement of Cochrane also to write interpretation. Intravenous tenecteplase 0.25 milligram per kg is reasonable alternative to alteplase for all patients presenting with acute ischemic stroke who meet standard criteria for thrombolysis. Obviously, inclusion, exclusion, and so patients with acute ischemic stroke meeting eligibility for thrombolysis IV alteplase informed by the Canadian stroke best practice disabling deficit less than 4.5 hours. Before I end say something towards the end, I will say this was what Bijoy has taken. Dear friends, don't count on 4.5 hours. Count 270 minutes. It's like a satellite launching where ISRO or NASA counts reverse counting. Oh, I have lost 1 minute, I have lost 2 minutes, I have lost 5 minutes. It should go that way, or only remaining so many minutes rather than hours. I am again strong supporter of that, counting rather than hours. This was the flow chart which Bijoy has given. Again, right. Now, what about the ESOC 2023? And now, almost just 2 months back. Finished on 23rd May, today is 23rd July. 11th European Stroke Organization Conference, ESOC 2025 in Helsinki. Again, there are now studies which say tenecteplase is the thrombolysis of choice. These were some of the abstract in 2023. For time, I didn't include the 2025. So enough number, the abstract number, and this that tenecteplase as compared to alteplase. Even in older patient, secondary analysis from the ACT trial. Even beyond and my dear colleague Dr. Vineet often talks, we say extended window, he always talks beyond guidelines. But as Puneet rightly said, we have to be careful about the legal issues. So this was another one. So this was about elderly patients. Some are highlighted. TNK was as effective in minor stroke and safe as alteplase. And intravenous tenecteplase has a similar effect on outcome as alteplase without increased risk of symptomatic hemorrhage, even in posterior circulation. We know that 6.4% in NINS trial, and while it is less than 1/3 of the tenecteplase occurrence and 0.6% mortality in alteplase. Then clotbuster, this is for audience. Which one? Once I sat and discussed this, I wrote this. RTP or TNK? Why prefer one over the other? What is the evidence? So this is the slide, very important, I made myself because I could not find anywhere. RTPA versus tenecteplase, both are effective in ischemic stroke. Window up to 4.5 hours, window up to 3, but Werner Hake ACUS 3 showed that we can go up to 4.5. Those 0.9, 0.2, now 0.25. Now, only one aspect we have to see, that we lose 1 hour important in TPA compared to the TNK, because TNK will be given as bolus, that's 10% and 90%. Efficacy almost equal, or we can say TNK is non-inferior. Adverse effect same, adverse effects except the hemorrhage chances are less. Administration over a period of 1 hour, administration over a period of minutes. So that's the beauty of tenecteplase. Expensive, I think it's sleep time for Puneet. Relatively cheaper for the tenecteplase. Now this was I did the India Mart. I chose about Actilize 90 milligram, tenecteplase 20 milligram. By and large, even if 80 kg we give around 20 milligram, you can see the cost 49,499 or 49,359, and here it is 28,300. So almost you can see the cost is 60% of that of the RTPA. Thank you so much for kind attention. Another thing, we all should be aware, we talked of factor 2, we talked of factor 10. Now factor 11 is in vogue. There are a good number of studies which are going. One has stopped, one is going on. Milvaccine study world over, we are part of that. And the other is the Ascendexnat study. That has stopped, but 11 doesn't alter the homeostasis. So that may also become one of the future where there's a less risk and may replace sometimes even thrombolysis, and it even replace the antiplatelet agent because of safety of the hemorrhage. So with this, I'll stop my presentation, and if we have any question, shall be happy to take. Dr. Puneet, any comments, sir?
No, sir.
Dr. Puneet?
No, sir. No comments.
Dr. Satyanji? Anything
No
you want
comments.
to add further?
No.
Okay, Dr. Pratiksha?
Yeah, thank you very much, sir, for that excellent outlook that and conclusion that you gave. And also thank you, Dr. Satyananda, for excellent case presentation and a very good discussion. And definitely Dr. Puneet sir for a good moderator, and Dr. Amit as well to ask and interesting questions. So thank you very much, everyone. I guess till we meet next time, then good night, everyone.
Bye.
Good night,
Thank you,
everyone.
sir.
Thank you, Dr.
Thank you, sir.
Puneet. Thank you, Dr.
Thank you,
Satyananda.
sir.
Thank
Thank you, sir.
Thank
Thanks a
you,
lot, sir.
sir. Thank you, everyone. Thank you.
Dr.
Thank you,
Satyam,
Amit
good,
ji.
nice
Thank you.
presentation. Thank you.
Thank you, sir. Thank you,
Thank
sir.
Bye-bye.
Thanks. Bye.
Recording.